for absence?
Chair, I have apologies from Pauline Davidson.
And I believe Councillor Hume has come as a sub for her. So welcome. Thank you for substituting Pauline. The minutes of the last meeting held on the 6th of January have been circulated. Can I ask for a proposer and seconder that they are a true record? Councillor Green and Councillor Smith, thank you very much. Disclosure of members' interests, not usual on this committee, but does anyone have anything they need to declare? No, that's fine. Item 4, Health and Wellbeing Board. The report for their meeting on the 22nd of January, it's been attached. Do we just to note that? Are we happy to note that
Noted, Chair.
report? Thank you, Councillor Hunter. Now, the first substantive item, a very important item, is GP access. Welcome to James Martin and Graham Sayers, who should be joining us online to present to us. So I'm over to you, James.
Thank you, Chair. So hi everyone, my name's James Martin. I'm Strategic Head of Commissioning for Primary Care across Northumberland and North Tyneside within North East North Cumbria Integrated Care Board. It's the longest job title I've ever had. It might be the longest one I ever do have, but can we get the presentation up? Great, thanks. So today I was just going to talk to you a little bit around what general practice is, talk a bit around what the data currently shows us around GP access, talk a bit around some of the challenges and kind of some of the things we're trying to do as a commissioning organisation to improve access in Northumberland. I'll probably not focus too much on this. Obviously the slides have gone out, but I thought it was useful to have a bit of context and a bit of understanding around what general practice is. So it's often that first point of contact you would make with the health care services. So primary care first, and often you would go secondary care would be a follow-up from that. So they would refer you in there for further diagnostics or treatment, for example. General practice are small to medium-sized businesses effectively, and they have to have a partner, a contracted partner on their contract, and they're the ones who hold the NHS contract. So effectively as a commissioner we contract with a partnership, and they are individual contractors. The contract, there's three types of contracts. There's a GMS contract, a PMS and an APMS. Now all of our ones in Northumberland are GMS or PMS. This is a national contract. So it's not something we locally negotiate, it's something that's nationally mandated, and that's a contract that's held in perpetuity by those practices. The core functions, and a lot of the core parts of that is that they have a registered list, so they keep a list of all the patients that they look after, that they provide essential medical services to those patients, and they cover the geographical area to do that. I think, and that's kind of about it. The contract doesn't get into lots and lots of detail, so there's a level of interpretation around that, and we can see that in the slightly different provision that some practices, the way they provide their appointments. So there's nothing that says you have to do it in a certain way. It's that you provide your essential services within core hours, and those core hours are 8 till 6:30, Monday to Friday, don't include weekends and bank holidays. Payment through to GP practices it's not on an activity basis. It's not every time you see a patient you get paid a certain amount of money. It's effectively a fixed amount for the year based on the number of patients you have, and that's worked out at a price per patient. So they get a set amount to try and figure out this is my costs from a buildings and a heating and a workforce perspective, and here's the amount of work I need to do. Okay, so that's a bit around GP contracts. The other name that you might have heard is primary care networks. So these were established in July 19, and effectively they are collaborations of practices working together, usually in a geographical footprint, and they have a nominated clinical director that leads those. So they aren't a organisation, they're not a legal entity, but they are a collaboration of practices working together. There's 6 PCNs in Northumberland, and they support additional work such as they provide some enhanced access, so appointments. They've supported a lot with vaccinations, a lot on COVID-19, some do flu vaccinations, for example. So it's a name kind of that's becoming more common and more commonly used as a kind of addition to your core general practice. So in Northumberland, we have 36 GP contracts. So that's 36 GP practices, but we actually have 60 surgery sites. So this has come around from where previously about other practices and they'd merged together. So it's one contract, but they might have kept other sites. So it's a large number of places where patients can go to be seen. Comparatively to some of the other places we have in our ICB, this is a lot. But that reflects, I think, the rural nature of Northumberland and having some access close to people. Our smallest list size is just over 2,000 patients. Our largest one is just under 50,000. So I think that shows you some of that range that we have in terms of size of contracts. Obviously, those larger ones have multiple sites to support that. As I said, we've got 6 primary care networks and we've got a registered population of 344,000. So the registered population is the patients who are on a GP list. So they don't necessarily have to reside in Northumberland. So we have some patients that live in Scotland that are registered with a Northumberland GP. Similarly, some that will live maybe in Newcastle or North Tyneside and go over the border. Okay, so in terms of what does the data tell us? So I've tried to pull together some of the key data sources we have available to us that kind of show access or factors that might impact on access. So that first graph with all the lines in the orange, the grey, the green and the yellow kind of just shows activity over time and the number of appointments that are provided each month in general practice in Northumberland. So you can see kind of by the average lines that that's gone up and that's increased by 14.3% since 2022-23, so kind of just post-COVID to 2025-26. This is more than we've ever provided. So there are more appointments being provided year on year. So access is increasing, I think we can say. And the number that kind of gets me is 207,000 appointments a month, and we've got 344,000 patients on that list. So we're talking a significant proportion of the population. Now, some of those people will access multiple times. It's not individual people. But a lot of people that live in Northumberland are accessing their GP every month. So it's a huge amount of footfall, a huge amount of activity that's being provided. The second graph with the blue, orange and grey lines shows that comparator of Northumberland versus the ICB and then the England. And these have been done as rates per 100,000. So you can compare them. And you can see that in Northumberland, kind of that line tracks above both the ICB and England. So there are more appointments provided per 100,000 patients in general practice in Northumberland compared to the rest of the ICB and then compared to NHS England again, to England as a whole. So that's again positive in terms of comparatively. This slide really is just to show the level of variation within that. So it's all well and good saying here's Northumberland as a total, but we know there's variation at practice level and that demonstrates this, that there's quite considerable variation between the maximum and the minimum number of appointments that are provided. When we talk about who's providing them, so the first pie chart there is shown by healthcare professional, so around 41% of appointments are provided by a GP, slightly lower than the national average. And I think this shows that we're kind of broadening the skill mix within general practice more. So you are more likely to see a nurse now, you're more likely to see an advanced care practitioner, it could be a nurse or it could be a pharmacist, for example. And there's been a need to diversify the skill mix. When we look at the types of appointments that are provided, most are still face-to-face, so 2/3 are face-to-face appointments. We still see around 1 in 5 is through telephone. I think the number that's growing the most is through online video consultation, and that's increased by around 7% in the last few years, so that's going up. And I guess that recognises some of the new models of provision in general practice, which I'll talk about in a bit. And also, I guess, some of the rurality, again, that we've got in Northumberland, and actually sending an online consultation may work better for some patients than having to travel, and they can get the response they need from their practice. So these graphs just show an example of just those face-to-face ones, because I know that's often an important metric for some people. So we can see that Northumberland and East North Cumbria ICB are roughly around the same, again more than England average. And you can see how that's changing over time. So that is decreasing over time, and I think that recognises what I just said, that there has been an increase in those online consultations. And that graph in the bottom right kind of shows that steady climb over time in those that appointment method. This one shows the waiting times, so kind of how quickly from when you want to be seen do you get to be seen. So you can see the vast majority of patients are seen on the same day. That's still the biggest proportion, and then there's kind of a little bit of a dip for one day, and then it increases kind of to 2 to 7 days, and then kind of decreases again. I think the bit I take from these graphs is roughly the same. If you look at the pattern of all those three, Northumberland, North East Northumberland, ICB in England, it's a fairly consistent pattern in terms of the numbers and the split between same day and kind of following weeks. These graphs showed kind of workforce trends. So you can see the number of full-time equivalents, FTEs, for all staff, for GPs, nurses, direct care, patient care. So these are kind of non-GPs or nurses. So these are like your clinical pharmacists or physios, etc., that may be employed, paramedics within a practice, and then the total administrative staff. I think the positive there is they're all going up, is what I take from that. So the more staff we have available, the better that situation is for practices to be able to provide kind of more appointments. And this just shows some of that benchmarking across the rest of the ICB. So kind of the important things I took away from this was, so GP, full-time equivalent per 100,000, Northumberland's got the most kind of per population in our ICB. But actually when you look at nurses, kind of it's third from the bottom. So there's certainly some risks there and some things for us we need to think about in terms of maintaining nurse provision and how we can bring more nurses in. Okay, so that's the data. They're the numbers, and I think when you look at that kind of tells a somewhat positive story that comparatively access in Northumberland's better than some of the other areas, and that it's increasing. So they're both good things. But I think the thing to balance that with, and the important factor is when we look at our patient experience, it doesn't necessarily tell us that. And I think this is some of, I was saying before, I don't think I know someone who's either not had challenge at getting an appointment, or has a family member who's had a challenge getting an appointment with their GP, or has a friend has. And you can see this in the GP patient survey data. So this is a national survey that's done, asked for patients from every practice to feedback. And we can see that the percentage of patients that found it easy contacting their practice on the phone is 55% in Northumberland. So that's nearly 1 in 2 is saying that they struggle to get through to their GP practice. That's a huge number. That's not a small amount. And that's something that needs to be worked on. 85% said they found their receptionist helpful. Kind of 72% were satisfied with how long they had to wait for an appointment. So that's kind of nearly 1 in 3 that weren't. 44% were able to see the professional that they wanted to choose to see. Percentage of patients who would say that their experience of contacting their practice was good, 73%. So again, significant number are saying, no, it's not a good experience for me to be able to get an appointment. And the proportion of patients who rated their overall experience of their practice as good, so that's everything, that's contacting, that's your consultation, etc., was 79%. So there's some comparatively good scores there compared to NHS England, but I think when you look at the actual numbers, there's nothing there to be, I would say, significantly proud of, to say that that's a good experience for patients. So that's what the data shows us. In terms of access challenges, one of the biggest ones is capacity. So GP practices are able to employ a fixed number of staff on the funding that they have. They may have a fixed amount of space in their estates, so actually, are they able to do more? Is there opportunity for them to do more, and is that restricting the number of appointments that they can offer? We know that there's increasing demand, and I think if you look at, so this data talks through the trend in number of patients over 60, and you can see it's gone up 25% in Northumberland between 2015 and 2025. And it's projected to go up another 16% in the next 10 years after that. We know that age is a definite correlating factor to the amount of healthcare needs that you have. So having an older population, there'll be more people who will need to access their practice or their GP as well as other healthcare services. So demand is increasing, and as well as capacity increasing, demand may be increasing a greater amount than capacity. With that kind of increase in our older population, there's increasing complexity in terms of the clinical needs of those patients. So we have a lot more patients now that have multiple long-term conditions. There's polypharmacy, where they're having to kind of manage multiple medications and are having complicated prescriptions. So that complexity takes more time to manage and more time to look after, and therefore more resource. And I think the final challenge I'd talk about is just increasing scope. So within the 10-year plan for the NHS, there's a lot of talk about kind of moving towards prevention. And there's a lot of talk about something called the left shift, which is having care provided somewhere closer to your home and not having to go to hospital for that. So they're both really good things and both really important things for us to try and move towards. But that increases the amount of things that we're going to be asking general practice and community services to be doing and providing. So effectively, we are going to be looking for them to do more as well. And we'll have to provide resources to do that. But that's a challenge. That's an additional challenge into the mix. So there's some of the difficulties. And then in terms of, okay, so just want to talk through some of the contractual changes that have happened. So on the 1st of October 2025, there was some amendments to the GP contract, which is a national contract. Effectively, this is ensuring that contractually practices should keep their online access turned on during core hours. And that's kind of aimed at trying to reduce some of that 8 a.m. scramble. So if you can fill in an online consultation, and that gets, you could say, actually, I've been told I need an appointment, or you could use that to check something or raise an issue. They could respond back to you electronically, and that may resolve your issue, or it reduces the number of people who are phoning and having to feel that they need to phone at 8 a.m. There's some elements around GP Connect, which is a way of getting the practice clinical system, which has all your patient records talking to other healthcare providers, so things like community pharmacy. So you could maybe go to your pharmacist through our Pharmacy First scheme, who can manage some conditions, and they would have access to your the information they would need to make that a higher quality consultation. And then there was a requirement for every practice to publish the You and Your General Practice mandate on their website, which is really setting out what the ask is around their provision of services. So every practice has that on their website now. The new contract for 26-27 has just, the first information came out around that last week, and that has a specific focus on access as well. The focus on access in that is really around if you are deemed, the patient has a clinically urgent, has been defined as being clinically urgent, then they need to be dealt with on the same day. And that's been very clear in the new contract, so that's something that practices are going to have to ensure. I think most practices do that anyway, to be honest, but I think that's just there to ensure that that's something that happens. And there is some shift of funding to focus around employing more GPs, particularly newly qualified GPs in practice. So that's something to push into the new year. So one of the programs to try and improve access is something called Modern General Practice. And this is a model that some practices have implemented very well. Some practices have struggled with and said it hasn't worked for them. There's not a mandate to say every practice has to use this, but we are supporting practices to move to this model. And the main gist of this model is around triage. So if everyone is phoning in currently or contacting their practice, if you just see them in order of when they contact your practice, you may not be seeing them in the order of need, just the order of the way they've got through. And the idea around triage is that you collect more information and you can then look across and go, actually, this person who contacted me 8th has actually got the most important need and they need to be seen right now. This person here who contacted, actually, they maybe could see them tomorrow, the day after. And it's trying to think a bit more smartly around the access that practices can provide. So in terms of things that we're doing to try and improve access, I kind of think about them in sort of 3 little chunks. So one chunk, if you're thinking, if you kind of thought of it as a bit of a machine, how could you do more? Well, one is you can increase the capacity, so you can make it bigger. So can you do more that way? So there are 382 additional staff employed now through something called the Additional Roles Reimbursement Scheme in Northumberland. So that's funding and made available through PCN. So that's quite a considerable number of additional people to see patients. Over winter, we commissioned an acute respiratory infection service, and that was additional appointments for So people kind of with those coughs, colds, etc., they can go. Some of those provided on a hub basis, some of those where it's more rural through practices, but that was additional capacity and additional appointments provided through general practice. We're actively trying to make our buildings bigger and trying to support practices to have more space so that they can employ more people and can see more patients. So there's around 8 GP practices that have secured capital funding to do some internal reconfigurements to create more clinical space. And we're also looking at 4 GP practices and working with them around relocation to some purpose-built facilities that will provide additional space and better quality space as well. We fund enhanced access through our PCN, so this is appointments provided outside of core hours, so 6:30 to 8 every evening and on weekends. We are looking to roll out, we had a population health management program that we've kind of done in North Tyneside, and we've been very successful. We're trying to think how we can best roll that out into Northumberland. So that recognises that seeing the same GP regularly gets you better outcomes, improves your quality, and actually has a positive impact on access. You're less likely to need to go to see the GP if they know you better. So improve access. The next one, can we make things more efficient? So can we do more with the same amount of resource? So some of that's around technology. So all practices have been supported to move to a cloud-based telephony system. So that's phone systems that allow them to track more data and understand when people are calling, and 2, have better queuing systems. So some have a callback function now where it will say you might be number 2 in the queue. You can hang up and you'll get a phone call back when it's your turn. Means people can kind of get on with other things. We've got a support team that's supporting practices with making some of these changes. So there's one thing saying we'll help you get a new phone system. There's another thing in terms of helping embed that within the processes within a practice so that they're using it in the best way possible. So that's what that team's there. And that's helping them with kind of online consultation processes. It's helping them with their websites to make them more improved, as well as helping with kind of, can we encourage better use of the NHS app and ensure that's embedded and working well. There's significant payments through the PCN DES, which are there to support PCNs in terms of, with their member practices, making some of these changes. And again, I mentioned the continuity of care initiative that we can take forwards. And then, so the other last thing you could do to help improve access is, can we reduce the demand on general practice services? So one of those is through our Pharmacy First initiative. So all the pharmacies in Northumberland are signed up to that, and that's seen over 10,000 patients now. So that's, instead of going to your GP practice, could you go somewhere else and still receive good care? We've kind of funded care navigation training. So this is training for receptionists and admin staff within practices to better direct patients to the right place at the start. There's still a significant number of people contact their general practice without a health need. There's often a social care need, or there's a need that could be supported through the third sector, for example. And this is about getting people to the right place. And then finally, we've kind of doing lots of work at the minute around neighbourhood working and neighbourhood teams. And that's got a big focus around proactive management of patients. So that's starting to look at frailty and can we manage frailty in a better way. And we've got a programme of work looking at care for children. So in terms of supporting children in the community rather than in hospital. So there's some of the bits that we're looking to do to reduce demand. I think that's it. So sorry that was a bit quick, but hopefully that gave you a good overview. I'm happy to take any questions.
Thank you very much. I'm presuming there'll be quite a few questions. I'll take them too. I'll take Councillor Hunter, then Councillor Smith, and then come back for the next one.
Thank you for that. It's a good presentation. I think it's getting that message out to the patients because, again, online works for some but not others. Absolutely. Not just because of the demographics and the capabilities, but often in rural areas they struggle with internet and that. And also it's trying to get people to understand you don't always have to see a doctor. Mm-hmm. You still have that old-fashioned way that it's the doctor you need to see if they're been advised, and it's getting that message out. And the other question I've got is, on the surveys that's coming back, are you actually drilling down as to why people are not satisfied with the service? Because I think that's the only way you can improve if you understand what the issues are. Thank you.
I'll just bring in Councillor Smith and then come back for the answers.
I was seeing GP practice has changed over the years and more is expected and resourced, etc. Are you having issues around recruitment and retention of GPs? Is burnout a factor as well? Too much is expected of you?
James?
Can I come in? I don't know if you can hear me,
Go for it, Graham.
see me.
Yes. Hi, Graham. Welcome. Would you like to answer
Hi.
that? Yeah.
Thank you. It was just, firstly, I just wanted to thank James. He's given a really comprehensive explanation of what goes on and all around the data. I'm a GP in ANIC. I still work 3 days a week in GP, but I sit alongside James's team with some other experienced GPs. So our role is to put into context some of this data with James's team so that if we see the variation, we then go with the curiosity to ask the questions and approach practices and think about the levers we can use to improve things. So it is a team effort, both with managers and clinicians at the ICB, to work on this. And we are perpetually looking at how we get the most effective and safe version of primary care that we can get. Just going to the councillor's question about burnout, it is a very real issue. Actually, if you look at the data on the GPs in the last 4 years, I think the overall increase in the number of whole-time GPs is something like 12 whole-time GPs in Northumberland. So if you think about all of that extra activity, it's by other members of our teams, and our patients are actually much more complex than they used to be. And actually our patients are often have relatively high expectations of us as well, which is not a bad thing to have. But yeah, it can be quite difficult. And I think there are some GPs who have left the service sooner than you would normally have expected because the intensity is such. The other thing that I don't think people quite realise is I work 3 days a week in general practice, and actually that's usually 30 hours. I also work in other areas of the NHS, but the intensity is such that if you try to do more hours in a week of actually in front of patients making decisions, it's incredibly tiring and draining. And we can only do a certain amount without that time that we need. So yeah, it's a challenge, but that's what the profession is about. And I think James's point about continuity is one of the most important things. The more we can keep continuous relationships with our patients, especially those that have more complex problems, the better the service is.
Thank you.
Thanks, Graham. Just return to some of the other questions Councillor asked. So in terms of digital, yeah, that's something we're very aware of in terms of people's ability to access, and there is variation in that around the whole of the ICB. So how can we support? There's some areas where there's kind of significant digital poverty, for example. There's some areas where there's less knowledge and awareness. So we want to move, and then the direction of travel is definitely to use more technology, and technology can help us be more efficient. But we need to make sure that that doesn't create more inequalities in terms of access to services. In terms of patient experience data, the national survey is limited, so it kind of tells us what, it doesn't really tell us the why, but every practice is expected to undertake some of that work locally. Derry and Health Watch are great at supporting that, and they do reports, and we've just commissioned a report recently that's kind of been looking at some of those wider determinants of access, has had a focus on pharmacy first and some of our enhanced access, for example. And we're kind of digesting that now and thinking about how we might need to respond to that. And I think that came with some very key messages. So one of them is actually there's not always a great understanding of what all these different terms mean and what these different ways of accessing services are in our population, and how do we promote that better, and how do we increase that. So how many people would know when they were asking for an appointment that they could ask for one in the evening or on a weekend, for example, and how do we improve that?
Great. I'll go to Councillor Oakley and then Derry and then back to James and Graham to answer the points that you two will have raised.
Thank you. Are you doing any work around the myth busting? There's a certain demographic who believe that they should see a doctor, but in reality you might see a nurse practitioner, you might see a nurse, you might see a pharmacist, whatever it might be. And I think the more work we can do around that, the more that your satisfaction rates will go up, because it will be interesting to see the breakdown of the age of those who are dissatisfied, because there might be a correlation there. The family doctors, if you've got a long-term condition, yes, absolutely, you would want that continuation of care. But in the main now, you see who you need to see to, if you've got a sore throat, you don't necessarily need to see your doctor. And I think there needs to be some work done around that. And the other thing I was going to ask was, is there a correlation, and I see that the PCNs are now going to open up at weekends, you said, and evenings, but is there a correlation between increased A&E trips and GPs being closed at the weekends, and is there considerations like, and I think the RVI's got a GP on site at weekends, is there something similar being thought about for Cramlington? Thank you.
Dairy? I'll bring Dairy in, and then if you have your pen, and because I think Dairy will have a few points.
Oh, yes, I did have 2 pages, but I think people have brought at least 1 page up already. Thanks very much for that, James. I think it really does encapsulate everything that we at Healthwatch hear about general practice. And I think it needs to be said that positive experiences that we hear show that the model can work well, because we shouldn't always say that we only hear negative, we do hear positive examples as well. So when staff explain options clearly, systems align smoothly, and digital and non-digital routes both function well, then what we hear, people report to us that they get quick access, confidence and satisfaction in their service. So I think that's a really important message, that it takes a lot for the systems to align, but when it does, it works. And I think that's probably something to hang on to for all of us. But I think when we look back at the feedback we get about GP access, 5 issues come up time and time again. And I won't reiterate all of them, but what I will say is that 2 of them are around online access or aspects of online. Some of that Councillor Hunt has already alluded to in terms of actual how to do it and whether it actually works for everybody. But I think one of the issues that we're hearing more and more is that people feel they're being forced to go online. And again, that feeds directly into satisfaction levels. So if people don't think they've got an option, then I think they feel already that they're not quite getting the service they expect. I think the other thing that you've said very clearly, and I think that's absolutely right from what we hear, is that people don't have awareness of the new services. So extended access, I was talking to a group in the south of the county last week, and nobody in the room knew that there was such a thing as extended access. No one had been offered it, no one had used it. And from what we hear from other places, that's not unusual, and I think you said the same there. So I think there is a real issue around the awareness of these things and actually how they're being offered to people. So I think that's probably quite important. But I think one of the things that we hear is some of the ways that the system works around barriers for people. So if you're not quite, you don't fit the sort of cookie cutter presentation, and none of us do, then it can be a problem. So I think people who face the most barriers are probably the ones where you probably need to focus. But I think, again, going back to what you've said, a lot of what we're talking about here is what is the patient actually experiencing. And I think our biggest recommendation around some of this would be to get patients re-involved in some of this. And we've been an advocate for patient participation groups since forever, and we know that they've not really come back since the pandemic, and changes in all sorts of parts of the system have not worked. So we would be saying that, a lot of this promotion and getting the information out and getting people more involved, and I'd love to hear your views on patient participation groups and how they could be brought in to help find the solutions to some of these issues.
James, do you want to come in first?
Yes, I wasn't sure if Graham wanted to pick up anything briefly. I'm happy to, Graham. I just wasn't sure.
I'm here. I'm multitasking a little because I am duty doctor, so I'm doing my best to keep GP access running while I'm here.
There's a queue
I
outside
think
your door.
I'm happy to...
Derry has worked really well with us around the issues around multiple different people providing care. She's been to LMC meetings. There is a guide that was distributed or developed for patients. I'm not sure how well we've done on the engagement of the information. So I think it is a really good point about what people expect from their GP practice these days. I also think this tension between using technology at my end, the more information I can get in a very clear way to allow me to decide efficiently the best person to see that person is really important. On a Monday in this practice, we receive upwards of 300 requests from patients, and we have to decide out of them who needs to see who and when, and that's the most effective we can be. But not every practice has that system. Smaller practices where they know their patients better, their patients behave in a different way as well, so it's really complex and subtle. But I do think there should be multiple different ways, and those who are not tech savvy need to be helped, and we shouldn't have any barriers there. Extended hours is always a tricky one, I think, because we would really like to have the resources where we know our patients best. And sometimes patients use extended hours because it's convenient, and actually it's not the most appropriate place for them to go. But that comes back to that, what's the problem? And can we teach people, I don't know, teaching feels too patriarchal. Can we give people the means to understand where best they should go and nudge them in the right directions?
Thanks, Graham. Yeah, so I think it's fair to say there's a lot of really good clinicians in our practices who aren't GPs. And I think the data shows their patient experience of the consultations with those clinicians is also very good. So I think there's something around, once you've experienced that you've seen someone other than a GP, you actually kind of recognise that that is an option. But I think there are some challenges to people universally doing that. Sometimes that is that you may see another clinician and end up having to see a GP anyway, and then you feel in that situation, well, I could have done that in one appointment. And similarly, we've got a lot of people who don't access general practice very often. Most of our population would access relatively rarely, kind of once or twice a year. So to understand the very complex system of lots of, I see this clinician for this, and this one for that, and this person for someone else, is a lot for people to take in based on their level of interaction with the service. And that's where some of that care navigation stuff comes in. So as a person who's meeting you at the front door effectively, can they help direct you to the right person and help you understand why that's the right person to go to? So having a physio in a practice, which lots have access to now, is great for MSK issues, and actually often better than going to see the GP first. And that's the sort of kind of conversation we need to be having at that point, so people understand and we can educate people. I think the most learning that I've seen is from experiential learning, so people kind of having kind of an experience with one of those clinicians and it being a positive experience.
Can I just come back on this one, Chair?
Of course.
Yeah.
The physio is actually a really good example of that, because I've had residents come to me who've complained that they've been sent straight to the physio with no explanation why, and I think maybe a little bit more education around this is why this has been done, rather than just, you know. So
absolutely.
it was actually a good point, yeah.
In terms of, someone asked around A&E as well, so in terms of, so there is a GP out of hours service, so when the practices are closed, there is an alternative GP service that's there that provides, kind of often we'll go out and do home visits, or and there's quite strong links between certainly our urgent treatment centres in kind of Alnwick and Berwick and what else we've got, Hexham, that there are GP, that they align with that out of hours service, so there is GP presence in those. So there is kind of that alignment already, and there's a recognition within urgent services that actually having GP skill sets are quite useful in those settings, and can support them with the provision of those services. It adds another challenge from a workforce perspective if we've got GPs working in different places. But as Graham said, lots of GPs work across multiple places, so we have a number that work in general practice and also work in NSEC, for example, or work in some of our urgent treatment centres. And And then I think the other point was just in terms of PPGs for dairy. So yeah, so I think there's an ask there that all practices kind of understand, and when they're making changes, that they engage with their list and with their patients. And we see that on big changes, so where there's a relocation, for example, or a practice merger, there's significant engagement around that and what that means. But what we need to make sure they're doing is they're doing it on some of the smaller stuff as well. Now, a PPG may be the right way to do that, but there are other ways that practices can engage with their list, and actually sometimes that gives them a broader level of feedback than maybe the PPG did, which can often be quite a similar population, I would suggest, that make up that. So we always push practices to ensure that they're doing that and that they have a way of getting that feedback and they are engaging where they are changes. I think a PPG is a useful sounding board, so I agree with what you're saying, Derry, that I would encourage all practices to have one, but I think we have to recognise that there are other ways that practices may do that engagement, and similarly primary care networks may do that engagement in other ways as well.
Great. I am going to be making a recommendation shortly for some follow-up work. So just bear that in mind. This is definitely not, it's too important issue for this too. Right, I'll come back next year. It's definitely not. But I will take some more questions. Does he, Councillor Hume, did you have your hand up? Councillor Hume.
Thank you, Chair. I'm from Amble. My ward is Amble, but I'm standing in for Councillor Davidson, who is infinitely more qualified to do this than I am, so please bear with me. Amble's population has grown by over 1,000 expected in the next year or two. Our medical centre is very difficult to access, either by phone or by just turning up. I was wondering, what can we do to improve connections with doctors, nurses, etc.? Is it possible to get a walk-in centre, or is it possible to get another centre? And if so, how do we go about that?
Okay, so I think the most useful thing would be to take that outside this meeting, and I'm happy to have a conversation with someone around kind of those practice challenges. So certainly as a commissioner, there's growth in the population in different places around when there's new house builds, for example, and we need to make sure that we can try and adjust for that and support the practices to be able to manage kind of an increase in their demand through changes such as population changes. And that kind of recognise, I mentioned some of the estates work we've done around trying to improve the existing estate. We've got to be able to manage some of that, and sometimes that comes from Section 106 funding or funding attached to local growth. So that's something we can have a discussion and have a look at how that will be working. I think from an urgent treatment perspective, kind of there's quite a fixed commissioning process for that, in terms of we've kind of done lots of work to understand our needs. And if that would significantly change, then we'd need to look at kind of what our provision is. Kind of they work better around kind of bigger centres that people can travel into. I don't know if we would be looking to increase those numbers as we are now for a population increase in one area, but if there was a kind of a significant increase over a bigger population area, we would need to revisit and look at what our urgent care provision would be and need to be to meet that local population need.
Thank you very much.
Okay, I don't see any other hands. So I'm going to summarise by getting back to the essential point and concern. We as councillors, and actually we don't need to be councillors, members of the public, hear day in, day out all the problems of getting access to GP. The problems and risks of that are obvious. The risk of early death is obvious by not getting a diagnosis. The perception, even if you haven't been trying to get a GP recently, that it would be too difficult, potentially cost lives. So it's a very serious issue, and there's a danger sometimes when something's so obvious and with you all the time and very difficult, you can shrug your shoulders. But what we want to do in this committee is do all we can to really identify the problem and potential solutions. So I'll speak slowly for the for the minutes. But I'm going to make a proposal. First of all, I'll ask if anyone makes any tweak to the proposal and just ask for an acceptance, and then some vote for some representatives. So I would think we need to set up a task and finish group to examine in depth the issue of GP access in Northumberland. This would be chaired by my Deputy Councillor Veronica Jones, as in line with best practice and normal procedure in this council. It would have Derry, who could be substituted by somebody else from Health Watch, would sit on that, and up to 4 other councillors. You'd be able to have substitutes if you can't attend, and full flexibility in terms of inviting people to the meetings and evidence gathering. I'd ask people, when I look for the 4 nominations, to consider geographics, so people are represented, because we have issues with capturing the data. At the first meeting, it would be agreed the full terms of reference and methodology and timescales. It may be the finish as a report, and it might still, the committee might not self-finish fully, but the finish would be producing a report which would capture what residents are telling us, but also what we're hearing from all relevant parties, to really get a very helpful in-depth report. Can I ask, first of all, just for a show of hands, if people think that's a good way forward? I'm happy with that. Okay. Now, I'll ask for, this is additional to Councillor Jones, in addition to Derry, for 4 members. Can I just, first of all, this is about the geographic split, propose Councillor Hunter, who represents another bit, which, so we've got the north covered. So, Councillor Hunter. Is everyone happy with Councillor Hunter? Now, look for 3 more people. Somebody from the south and somebody... Are you nominating yourself? Yeah? Remind me what ward you are. Okay. You're Cramington. Great. Perfect. Okay. Thank you. So, everyone happy with Councillor Smith? 2 more? Councillor Green. Where do you represent? Great. And as I say, you can have substitutes if you can't come. And final one? Yeah, somebody to the west. I think Veronica's the most west. Does anyone else want to? Should we put you on? It's quite good to get political split, so everyone's speaking to colleagues, and it's not political as such, but so everyone. And then obviously one of the emails around would be what suits people. You can obviously have meetings online as well, so that, and the substitute, so if you can't do, we could substitute somebody on and agree at the next meeting. So that's fine. Is everyone happy with that as a way forward? You count, because you'll be chairing it, obviously. Great. Well, thank you very much for that. Really appreciate it. And thanks to James and Graham for coming. Really appreciate your input. And if you've got anything else you want to input, particularly to help form the terms of reference or anything else, in confidence, you know, to just inform our thinking, please let Rebecca know.
Great, thank you. Happy to help where we can.
Brilliant. Thank you. The next item is pharmacy provision in Northumberland. We have Adam Pendlebury, is that right? And Sharon Williams. Do you want to come up, Sharon? Or you? You're present. You're okay. So if there's any, you're fine. There we go. Okay, lovely. Over to you, Adam. Thank you.
How do you put it on, James? There we are. Good afternoon, everybody. Lovely to be here. I'm Adam Pendlebury, as been introduced, representing North East North Cumbria ICB. Part of my role is a primary care manager. I oversee applications coming into North East North Cumbria within the remits of the areas that I cover. So that's a little introduction to myself. got apologies from Ken Youngman, who is the Strategic Head of Pharmacy and Optometry. So I'll be presenting today. Just sort of moving on to the current pharmacy provision within Northumberland. There's 65 community pharmacies delivering pharmaceutical services, all registered to provide pharmacy first. With a little bit of a breakdown in this, there's 61 40-hour pharmacies. There's one pharmacy providing 35 hours, and 3 which are contractually 100-hour pharmacies. However, 2 of them provide 78 hours and 1 provides 72 hours. Within this, we've got 2 distance selling pharmacies, which are based in Northumberland, and 26 across Nenk ICB as a whole. So that's a little bit of a comparator for you there. The current provision, I've included 2 maps in this, and as you can see, it's quite congregated within the sort of the east of the county, with a lot of rural sort of split throughout the rest of it, you know. It's got a breakdown within that of the pharmacy type, whether it's a 100-hour or the 40, as I've mentioned. Access to pharmacies and challenges in Northumberland. Since the publication, which is in October of 2025, it's worth noting that there's been 0 pharmacy closures across Northumberland. Access to community pharmacies across Northumberland is well provided for Monday to Friday, 9 AM till 5 PM. All localities include at least 100-hour pharmacy and some services at the weekend. Access to pharmaceutical services across Northumberland is strong, with a well-distributed network of pharmacies ensuring residents can easily obtain essential NHS services, aside from one isolated area under active review. Provision remains reliable and responsive to community needs. And in my next slides, I will touch upon that area where there does appear to be a gap. And I'll sort of go into detail about what we're doing to aid the resolution on that. So here we are. We've got that there's a need for a pharmacy highlighted in the P&A. That's in the southeast locality, and there's a current need for essential, advanced and enhanced services in Newsham within Blythe, and that's Monday to Saturday. It's worth noting that there's an extant grant in place for a pharmacy, and we've just received today actually the notice of premises, which was set to expire tomorrow, so that's coming in time. So that's a positive bit of news for the residents in Blythe, Newsham. There is sort of 3 further applications which are to be heard at PSRC at the end of March. So there's a sort of a need to sort of provide services in that area. Uptake on advanced services, as James alluded to earlier on, all community pharmacies across Northumberland continue to provide a positive role in the area, you know, in delivering high clinical quality care. It's worth noting that all pharmacies provide pharmacy first, you know, something I wanted to touch upon from earlier, which is hopefully negating some of the stresses on the GP landscape. The P&A highlights that pharmacies are consistently providing minor ailment support alongside services such as emergency contraception, stop smoking intervention, supervised consumption and end-of-life medicines access, demonstrating a well-developed responsive network that enables residents to receive timely advice, treatment and support close to home. Just made up that point with regards to the 67 pharmacies providing pharmacy first. And I've got some stats in there. So since April 2024 to January 2026, it's worth noting that there've been just over 10,000 GP referrals for pharmacy first in Northumberland. In the same time period, there was just over 3,000 GP referrals for clinical pathways consultations, just over 7,000 minor illness GP referrals, and 5 urgent medicine supplies for GP referrals. It's sort of well worth touching upon. I know this is all about Northumberland, of course, but the national constraints to pharmaceutical provision. It's worth documenting sort of the workforce challenges in medicine supplies, as it's recently been sort of it was communicated out in Parliament, you know, with regards to medicine supplies and the issues such as funding. In Northumberland's no stranger to that sort of challenge as well, you know. However, it does respond positively, maintains strong access, consistently delivering high quality clinical services. Each area has got its own provision, with sort of round-the-clock access in terms of Monday to Friday, as well as some cover on weekends. Touched upon the resilience and commitment of local pharmacy teams. Within the national context, residents are still able to benefit from timely advice and whatnot. Got in here stats with regards to network changes and density. There's also public feedback from the Health Watch that pharmacies are highly valued for accessibility and clinical advice. However, there's concerns about the closures, reduced hours and increased queues, and limited uptake of online pharmacies. And again, technology might play a part in this, you know, like due to sort of aging demographics and such like. Risks and future needs. The network's stretched, especially in rural areas with poor transport links. Got in there about GP dispensing, unlikely to expand without funding. So we know that's a national constraint. A future need for essential services if closures occur in the various sort of regions listed. So we do know that it's sort of teetering on the sort of hotbed of topical concern, shall we say, if one of those was to close. It does sort of, with the rurality of Northumberland, that there is the challenge there, you know, that we're no stranger to. Again, with the loss of any 100-hour pharmacy, it would create gaps in evenings and weekend provision as well. What might help pharmacies in Northumberland? So there's such thing as the settlement, baseline of the annual CPCF funding to 3.073 billion. That's adding 215 million for Pharmacy First in the primary care recovery plan services. And it's worth noting that while this increases may help, some may still face sustainability challenges due to the remaining gap. You know, we know that the funding will go to a length to sort of help negate this, but it won't necessarily cover it, you know. Again, got regulations are more flexible, allowing 100-hour pharmacies to operate 72 hours to support sustainability. Revenue comes from expanded services like Pharmacy First. We've got the blood pressure monitoring and contraception in there. And it's worth noting that NENG ICB funds a 6-year minor ailments service to increase pharmacy activity also. Got in there about local coaches and PCNs to promote Pharmacy First, blood pressure checks and contraception uptake. And we have got sort of programs in place to promote this as well, such as like they've got buses and whatnot, and pharmacy provision from not from a contractual base, you know. Got in there about the ICB leads meeting with health and wellbeing pioneer leads, including Northumberland, to discuss service areas. And that happened as recently as 2 weeks ago, where we're trying to work closer to sort of pick up on, or be proactive, shall we say, if there's any challenge that do occur. We'd rather find out in the first instance so that they can be negated against it quicker. Again, Northumberland Health and Wellbeing Board working closer to it. So I think it's striking up a greater relationship to overcome any such problems. Got in there about the ICB providing data to Northumberland Health and Wellbeing Board for the new P&A, which was recently published. Health and Wellbeing Boards assess the pharmaceutical service needs through the P&A. And on a monthly basis, the Pharmaceutical Regulation Committee uses the P&A reports to review pharmacy applications under the 2013 regulations. PSRC decisions on applications are based on these regulations, and Health and Wellbeing Boards are interested party who provide comment on these. So if there is an application received and it's sort of documented in there that the Health and Wellbeing Board have provided support for these applications, then that would sort of put a steer on the outcome of the application. So again, just touching upon there, that the continued dialogue and further discussions with P&A leads. Got in there about the meeting was scheduled for March, post-publication. I've referenced that it took place two weeks ago, and that there's a follow-up meeting, just to strike up those positive working relationships. As opposed to working in silo, you know, I believe it's greater to work better and closer together. And again, just touching upon the further engagement, you know, like for processing applications. I've referenced about the gap in provision in Blythe, Newsham. So the comments from the Health and Wellbeing Board do go a long way to sort of providing a steer on the outcome of the application, whether it's supported, and we believe that gap will be filled hopefully shortly. Got in there about the engagement from local pharmaceutical committee reps as well, such as Anne Gunnan and Grant Morris, engaging through neighbourhood health planning as well. And that brings us to a close. Hand the reins back over.
Thank you. Can I just ask, first of all, I was interested, we've heard about GPs being hard-pressed and burning out. An interesting observation I found, I always, in recent years, thought, and it was often said, pharmacists are a good resource. I often found they were available, readily available, and had time and happy to chat. More recently, I've seen pharmacists, and I've, go for my mum, and sometimes they're not available, and I'm thinking, God, you're looking a bit hard-pressed now as well. Is there evidence that pharmacists are seeing this with increasing demand?
Yes, without having the data here to back it up, we are seeing constraints and such in terms of staffing. You know, I think that's a national constraint. It's not just isolated to one area. And without sort of backing it up with stats as well, there might be evidence there where you sort of passing the problem on as such. I think stress levels amongst the pharmaceutical world is sort of probably rising through picking up this burden, shall we say. But
Sharon, do you want to come in?
I am a pharmacist and I represent community pharmacy all the time, so I work alongside Grant and Anne. But I do work in pharmacy. And yes, what you're saying is true. Sometimes we do feel as though we're under the pressure and there's more and more coming our way. But we are training our teams. And so in the likes of what James was saying about, different people in practice roles taking on different things, our pharmacy technicians are now taking on a lot more roles within the pharmacy. So the pharmacist isn't always the person who is seen for whatever it is you need. So, for example, vaccinations and things like that are often done by technicians now. So I've got that.
Councillor Austin and then Councillor Hunter.
Thank you. Just a simple question. As an area, are we getting the best out of the pharmacy system by using repeat prescriptions by post? That's the first question. And secondly, are we maybe scoring a few own goals by putting, they could well be valid restrictions, but restrictions on the drugs that pharmacists can give over the counter? I've got to a certain age where I'm not giving them. No, you have to go and see your GP. So I've tried to use the service. I'm then knocked back because I now have to go and see a GP. And then we're going back onto increasing GP load by me coming in and saying, could I have a tube of,
Bring Councillor Hunter in and then bring you back.
Thank you, and they're much welcome, especially in the rural areas, and it is the fear that something happens. But again, we're getting a lot more tourists and that coming up, and that's putting pressure on because, yes, they maybe should bring medication with them, but people can make mistakes, they can run out of medication and that, and it's that sometimes we'll nip into the pharmacy and see if we can get it. So if we did lose them, it's more pressure, but again, it's putting more pressure on the pharmacists, not just the general public, and as well as more development that's happening in places. The government's saying we need more house building, so therefore it's a knock-on effect.
Adam, do you want to come back on that?
Absolutely. Sharon, do you want to come in?
Sharon?
So in terms of what we can supply, it is very much regulated by the licenses on medication. So the way the system works is that we have to supply in accordance with the license. So that will be why you are being referred back to your GP. So that's a manufacturing thing. If that was to change, then, you know, pharmacy teams could maybe take on more of that. And the thing about the rurality thing, a lot of pharmacies have closed over the last few years. And what we don't want to happen is pharmacies to close in places where people need them. But the system is very, very, very fragile, and there are more pharmacies going to close because of the funding gap. Even though we've had that injection, there's still a massive gap between what it actually costs to run pharmacy and what we are being recompensed with. So the likelihood is that more pharmacies may close, which is worrying, but I suppose it's a balance between getting the service provision in the places where it's needed and allowing businesses to be able to stay financially viable. Because if we have too many pharmacies, then they won't be financially viable.
That's just to touch on what Sharon's saying. That's something that we assess in the applications that we receive. One of the key questions is, will the opening of the new pharmacy impact on the surrounding pharmacies as well, you know? I know certainly from government as well as price concessions as well, you know, for the rise in cost of drugs, which is affecting the market as well. But in terms of what you referenced with regards to repeat prescriptions, I believe that feeds back into patient care as well, you know. Maybe the GP want to keep a track, you know, if the treatment that you're receiving, you know.
I was going to ask about that. One thing that seems to work well recently is repeat prescriptions if it's not, and people ringing up and just leaving a message and then it's coming within hours. How widespread is that? I know you get that in Berwick, and it's a really good thing. People ring up, mum rings up, and then it's round in a couple of hours, you know, and it's not urgent meds either. But so is that available everywhere in Northumberland, that service?
Yes.
You get the delivery of repeat prescriptions?
Delivery in itself is a pharmacy service, so there's no funding for delivery.
No.
That's what they do themselves.
So the pharmacy themselves will be providing that service out of whatever income they have from whatever else they're doing. But the repeat dispensing side of things is something that has been pushed through GP practice, and, you know, so that people don't need to phone every time they need a prescription.
And what is the motivation for that? You're thinking why they're doing that's very good. Is it so they don't have loads of medicines lined up and people coming in? It's quick. Is it more efficient? I presume it's more efficient for them just having people going out delivering it rather than people. No. Eve, you've got some insight in that.
Pharmacies, with the delivery service, the recipient of that prescription has to actually be in at the time in order to receive it.
Oh yeah.
So it won't be put through the door, which is often what people actually are looking for, because they're out at work, they're on the school run, whatever it may be, and they can't make it to the pharmacy because of the time schedule. Not because they can't physically get there, it's because of the time, and the pharmacy is actually closed by the time they finish work. So it doesn't actually work for as many people as you might initially think. But for our elderly and disabled population who are less constrained by that, it is actually a very, very good service. Yeah.
Just to touch upon that as well, obviously we've got 2 DSPs, distance selling pharmacies, which do the delivery service. Further procurement, we've got an outreach facility within Harbottle, which contractually from Rothbury, you know. So that's a service that's set up to sort of combat the rurality of deliverance as well.
Thank you. Councillor Carr?
Thanks, Chair, and thank you, Adam, for that presentation. It was just to say thank you, and from what you yourself and Sharon have said about the pharmacy provisions facing this difficulty and financial constraints, to actually get Newsham pharmacy back open for the residents, particularly mine, and particularly the ones in Newsham who you know, when this pharmacy of theirs closed in 2024, with Northumberland being the biggest town and pharmacies being, you know, in probably the top 5 of essential services, that you've managed to get this one back open. So to everybody involved in that, you know, thank you so much on behalf of those. Regarding when you mentioned on the slide the technology factor, that the older graphics aren't taking up the online pharmacy service, it's interesting, Sharon, that you pointed out that obviously it's the pharmacies themselves who deliver these prescriptions to them, especially in the rural areas, and obviously the time it takes to get there and how far away they might be in the isolation. I do actually believe that over time this may change, obviously, as time progresses. All the people who don't take up the technology will eventually, ourselves, when we're older, we'll find that the online pharmacies will become more and more likely to rise, I would imagine. But again, as you say, it's depending on those financial constraints of what's actually available to actually get them the service to say, yes, if you'd like it, we'll come and deliver it to you. But I understand if it's a controlled drug, whatever the prescription is, I'm sorry, no, but you have to come in for this one, unfortunately. And those time constraints of people's lives and the opening of pharmacies and closing of them, there's so many factors involved, and I get that, and it can be difficult for you guys. But again, with what you're doing, I applaud you. So thank you.
Thank you.
More questions. Is there any final points you would like to raise? I'll first ask Adam and then go to Sharon, if there's anything you want to say.
Nothing, just thanks for the opportunity to come here today. Representing sort of North East North Cumbria ICB towards applications in the pharmaceutical world for Northumberland. Feel free to ever reach out to me via email if you've got any concerns, or if you'd want us to address any questions, anything as well, you know. I'll always sort of make sure there's time there to reply to them.
So you're happy for Rebecca to circulate your email?
Yes, yeah, that's fine.
Sharon, is there anything else you want to say?
Likewise, if there's anything I can help with, but also just to say, delivery is a great thing for people who need it, but we love to see people in our pharmacies because we can check their blood pressure, we can check they're using their medication properly, we can offer them other services that they don't get by having the medicines delivered.
Where were we? We were at a meeting, Rebecca, where they were suggesting dentists start doing blood pressure. And I thought, what are you talking about? People's blood pressure be through the roof in a dentistry. Great, well, thank you very much for that. That was really, and I think probably on the annual calendar, hearing from this, we'll obviously be in touch, but it's really useful to hear what's happening there. So thank you very much, Adam and Sharon, for coming in. The next item is the reports of the Scrutiny Office. Rebecca, over to you.
Yeah, the forward plans, just to note really, and just a verbal update on the work programme. We have added an additional meeting in towards the end of the month, so the 31st of March at 1 p.m. we will send out a calendar invite, which is where we will consider the mental health strategy, and we'll also be looking at the Cabinet report on the Foundry House redevelopment. But that's all for me.
Great, thank you for that. So that's the 31st of March for the next meeting. And well done, Reform, for reading the Constitution and finding out that you can have substitutions, because I think some people weren't aware of that. So do take that opportunity up to have substitutes if you can't make it. I don't have any urgent business, do you know? And so the date of the meeting is as discussed. And then after that, we still have the meeting on the 5th of May. So thank you everyone for coming, and I will see you next time.